Welcome all. Today we are talking about the thrombotic disorder. So the best example to start with the thrombotic disorder is deep vein thrombosis. So the deep vein thrombosis still mortality is 1 to 3% in this patient, and we have many predisposing factors for deep vein thrombosis, including patient factors that mean the age, obesity, superficial varicose vein, which is rarely complicated by deep vein thrombosis, previous history of deep vein thrombosis, family history, which is called the thrombophilia, and pregnancy, contraceptive, and puerperium. We have a surgical cause, which may be any major surgery which prolong more than 30 minutes. This is predisposed to the deep vein thrombosis, and those patients with abdominal, pelvic, or orthopedic surgery of the lower limb, they have high risk to develop deep vein thrombosis. We have a medical condition like patient with a myocardial infarction, heart failure, inflammatory bowel disease, nephrotic syndrome, pneumonia, and stroke. This increased risk of the deep vein thrombosis, and hematological disorder with the myeloproliferative disorder like polycythemia vera, essential thrombocytosis, and sometimes those patients with the inherited cause because of the deficiency of the antithrombin, protein C and the protein S, and you know this is the natural anticoagulant which prevent thrombosis. So when we have deficiency of these antithrombotic proteins, this lead to predisposition of the deep vein thrombosis. Paroxysmal nocturnal hemoglobinuria, which is an acquired rather than this is inherited, factor V Leiden and prothrombin gene mutation. Again, one of the unacquired cause of the thrombotic disorder is antiphospholipid antibody syndrome. So how these patients present? Clinically, these patients, they present with mainly lower limb deep vein thrombosis, because thrombosis can be occur rarely in the upper limb, but it is usually occur in the lower limb. And typically these patients, they have unilateral rather than bilateral. So they present with the pain, swelling, high temperature, and tender with the dilated superficial vein. And during examination, we found that this patient البيشنت he had deep vein thrombosis, especially those they have proximally involved. These patients, they have an increased risk of the pulmonary embolism. So the differential diagnosis of deep vein thrombosis, we should put on our mind whether spontaneous or traumatic calf muscle tear, which causes sudden severe pain in the calf area, rupture Baker cyst with a rheumatoid arthritis, and infective cellulitis. These patients present with the well-demarcated swelling and erythema and pain and tenderness. So to investigate this patient, we start with the D-dimer, and this D-dimer usually done for those patients who have low probability, and once the patient who have low probability and negative test, so this make the diagnosis is excluded. Second thing, which is the gold standard, is the compression ultrasound Doppler, with the sensitivity for this Doppler is 99% in the proximal, it's mean above the popliteal, while this sensitivity will be dropping down for those patients who have distal vein thrombosis. The contrast venography, this is now rarely used for diagnosis of deep vein thrombosis. So to manage this patient, we should elevate the limb and with the analgesia. Sometimes we use thrombolytic therapy for those patients who have extensive thrombosis with the life-threatening deep vein thrombosis, and those complicated with the dilated right-sided heart failure or pulmonary embolism. So the main treatment is anticoagulation, either with the heparin or low molecular weight heparin. So these patients, we should start with the anticoagulant like heparin or with the low molecular weight heparin, and at the same time we should start warfarin in order later on, after we reach the target of INR, to stop heparin and continue on the warfarin. So if strong contraindication to anticoagulant, we cannot give anticoagulant, and or the patient he had still, despite his own anticoagulant and the patient developed pulmonary embolism, we should use inferior vena cava filter. Warfarin should be continued up from 6 weeks to 6 months, and this is depend on the site of the thrombosis and whether it is there is a temporal cause or there is an idiopathic cause. So the duration from 6 weeks to 6 months. Risk of the recurrence is 2 to 3% per year in those with the temporary risk, while those patients with the unprovoked DVT, this patient, the risk is 10%. As you see in this picture, we have asymmetrical swelling in both limbs, with the right limb swelling more with the redness, and during the examination we see this, it is tender and it is hot. One of the complications of deep vein thrombosis is what we call post-thrombotic syndrome, and this is because of the damage of the vein valves by the thrombus, which lead to the persistent leg swelling, heaviness, discoloration, and sometimes ulceration around the medial malleoli in order to differentiate from the arterial ulcer, which is mainly occur in the lateral malleoli or the pressure area. What's the international standardization ratio, or what's we call it INR? This is the patient PT over the normal control multiplied by the international sensitivity index. So in warfarin, when we use warfarin therapy, we should have this INR, the target between 2 to 3. And you see that there is many indication for anticoagulation, including the heparin and warfarin therapy. The heparin, those patients who have venous thrombosis, who have undergo coronary intervention, post-thrombolytic therapy, unstable angina, non-acute myocardial infarction, acute peripheral arterial occlusion, whether it is cardiopulmonary bypass surgery. In those patients with treated with the warfarin, as we said, you should be superimposed with the heparin or low molecular weight heparin, and then later on you keep this patient on the warfarin, and you see the indication again for venous thromboembolism, arterial thromboembolism, arterial fibrillation with the stroke risk. We have a mobile mural thrombosis, extensive interior myocardial infarction, dilated cardiomyopathy, those patients who undergo cardioversion and or they have ischemic stroke, or this patient who have they have mitral valve complicated by the AF, or those patients with the recurrent venous thrombosis. Again, those patients who have mechanical prostatic valve, they keep lifelong on the anticoagulant. So the heparin, this is potentiate antithrombotic anticoagulant, antithrombin 3 anticoagulant activity. So we have unfractionated heparin and low molecular weight heparin. And the advantage of the low molecular weight heparin over the heparin, that we get it with the low molecular weight heparin 100% bioavailability. So this make patient, or this make this drug reliable dose dependent anticoagulation, especially it is dose dependent, and there is no need for monitoring except in very thin patient or patient with the renal failure, or during the pregnancy we may need to monitor this patient with the antifactor 10. Once subcutaneous can be used, especially in the prophylaxis, rather than an fractionated heparin, we should have continuous IV infusion in therapeutic dose, and sometimes twice daily for subcutaneously in those patients with the prophylactic dose. Again, the risk of the osteoporosis and thrombocytopenia, despite we see in both, but still it is less in those patients treated with the low molecular weight heparin. So the dose of the unfractionated heparin, you know that the dose of the unfractionated heparin, the therapeutic dose is 20 units per kg per hour, we give initially bolus 80 unit per kg, and then we continue on 20 unit per kg per hour, as we said, by the continuous IV infusion. And these patients should be assessed by the PTT, especially during the first 6 hours to reach the target, which is 1.5 to 2.5 times the control. In prophylaxis, we can use 5,000 units twice to 3 times daily as a subcut. Low molecular weight heparin, we have more than one type, despite the most commonly used enoxaparin. And the enoxaparin, the dose is 150 units per kg subcutaneous daily. And this is given as a treatment twice, or a prophylaxis be given 2,000 to 4,000 units subcutaneously daily. Tinzaparin, this is the therapeutic dose is 175 units per kg subcutaneous daily, and the prophylactic is 3,500 and to 4,500 units subcutaneous daily. So the complication for this anticoagulation, including the bleeding, and once the patient had bleeding while he is on anticoagulant, we should stop it. And especially for the heparin, the half-life, it is too short. It is just 30 minutes, so the bleeding most of the time can be easily controlled. However, sometimes it is necessary to use protamine sulfate in this patient. Another complication is thrombocytopenia, what we call it as HIT, and this is the divided into the early or late. Those patients who have heparin-induced thrombocytopenia after the first 24 hours, this is usually benign, and this is due to the platelet clumping. But the risk is there, those patients who develop thrombocytopenia after 5 days till 2 weeks after treatment of the heparin or low molecular weight heparin. These patients, they have antibody develop against platelet factor 4, and this lead to the activation of the platelet and prothrombotic state condition with the thrombocytopenia. So they have a thrombocytopenia, but at the same time they have thrombotic risk for this patient. However, this patient may be asymptomatic, or they may be presented with the thrombotic disorder, and actually they have poor prognosis. So how to manage these patients? So if the patient develop HIT with the heparin, we should stop it, but not use low molecular weight heparin, because there is a cross reaction with the heparin and low molecular weight heparin. So we use instead what we call direct antithrombin drug like leperiodine. Another adverse effect of the anticoagulant is osteoporosis, and this is mainly happened with the heparin if we use it for a long time, more than 6 months. What's about warfarin? Warfarin, this is inhibit vitamin K dependent factor, which is 2, 7, 9, and 10. And this is with the warfarin to be acting, it's need at least 3 days, and this is depend on how much we starting loading dose. So once we starting with the loading dose 10 milligram, we may get it the more rapid action of the drug rather than we use it 5 milligram. So sometime we need up to 5-7 days in order the drug to be active. So we need monitoring INR at least 2 successive days before we stopping the heparin or low molecular weight heparin, and depend totally on the warfarin. So the drug, we have the problem with this drug, we have many drug interactions, certain drugs which can potentiate, and certain drug which can be inhibit the action of the warfarin. So we need monitoring of these closely to monitoring of the patient treated with the warfarin. So the complications of the warfarin, as we said, can be complicated by the bleeding, and we have 1% fatal bleeding, and this is mainly intracranial bleeding. So how to manage patient with presented with the warfarin-related bleeding? So we need to look for the underlying cause, whether there is maybe the INR is increased because of drug interaction, or sometimes the patient they have voluntarily increase the dose of the warfarin. So what the first thing which we do it, we stop warfarin temporarily, and those patients who have minor bleeding, just we give 1 to 2.5 milligram 2.5 milligram vitamin K IV, but those patients with the major bleeding, we need to give higher dose little bit, 5 to 10 milligram, which causes, actually this causes a blocking of the vitamin, blocking the effect of the warfarin for a time. And this actually the vitamin K you should be giving infusion at just a few minutes, because if you give it directly, this can cause collapse. And those patients with the major bleeding, we need fresh frozen plasma, and the dose of fresh frozen plasma is 15 to 30 ml per kg. So once the patient who have prolonged AR but they have no bleeding, so just we stop the drug and reduce the next dose, and we resume the dose with the smaller dose, with the smaller dose of the warfarin. Dose of the vitamin K orally or IV 1 to 2.5 milligram, especially in those patients who have no bleeding but still INR more than 8. So we need to give, in addition to stopping the drug, we need to give vitamin K either orally or IV small dose, which is 1 to 2.5. So what's when we need the anticoagulant as a prophylaxis? Those patients who have moderate risk, or those patients who have high risk, and those patients who have moderate risk. So any major surgery, those patients more than 40 years, so they have a risk of the thrombosis. So we need to keep this patient on the prophylactic anticoagulant, and any medical illnesses like heart failure, sepsis, active malignancy, nephrotic syndrome, we need to keep these patients on anticoagulant. Those patients who they have high risk, especially those patients who they have malignancy, and those patients who they have abdominal surgery or orthopedic surgery, these patients make these patients at high risk for thrombosis. So the method of the prophylaxis in these patients, either we have mechanical or pharmacological prophylaxis. And I mean the mechanical prophylaxis either by using intermittent pneumatic compression or by the compression stock, or pharmacological by the use of the low molecular weight heparin or unfractionated heparin. So the contraindication of anticoagulant, we should not use. Sometimes it is, despite it is relative, and sometimes it is an absolute use of anticoagulation. So the patient who have recent surgery, or he had a pre-existing hemorrhagic state within, especially within 6 weeks, or the patient that he had like patient with the liver disease or hemophilia, these make the patient, they have high risk for hemorrhagic state. So this may be a relative contraindication to use anticoagulant. Those patients who have bleeding peptic ulcer, recent cerebral hemorrhage, uncontrolled hypertension, and those patients who they have old age, who are suspected, these patients, they are exposed to the frequent trauma. So be careful to use anticoagulant in these patients. As we see this patient who have, the first picture is related to the hemorrhagic infarction of the most of the small intestine, and this is because of the thrombotic in the mesenteric vessels. And the second picture is, we see that we have a large filling defect of the inferior cava, because this is due to the related to the large thrombus there. And this patient, again, we have a splenomegaly. What's about antiphospholipid syndrome? Antiphospholipid syndrome, so this is an antibody, and this is make it an acquired prothrombotic tendency, in which there is this patient, they have liable for arterial or venous, or sometimes mixed thrombosis. And these patients, they have an antibody, what's we call it, lupus anticoagulant antibody. So clinically, these patients, either we have primary or secondary antiphospholipid, and the secondary phospholipid related to the systemic lupus erythematosus, rheumatoid arthritis, systemic sclerosis, Behçet disease, and temporal arthritis. So the target for antiphospholipid antibody, either we have beta-2 glycoproteins, protein C, annexin V, or prothrombin. So this protein is the target for anticoagulant. So the diagnosis, how to diagnose these patients with the antiphospholipids. So we need to have a clinical and clinical in addition to the lab criteria. So clinically, these patients either presented with the vascular thrombosis, so either we said arterial or venous or small vessels thrombosis, or we have an adverse pregnancy outcome, especially during a pregnancy, to make the diagnosis of the antiphospholipids. So if we have one or more unexplained death, more than 10-week gestation, or 3 or more unexplained spontaneous abortion less than 10-week gestation, or 1 or more premature birth less than 34-week gestation. So this is the adverse, what we call adverse pregnancy outcome. And so if the female, she had this adverse pregnancy outcome and she had history of the vascular thrombosis, so one of them in addition to the lab, so the diagnosis make diagnosis of the antiphospholipid syndrome. So in addition, this patient may have livedo reticularis catastrophic or disseminated antiphospholipid syndrome, transverse myelitis, skin necrosis, and chorea. So this is the features of the antiphospholipid antibody syndrome. The antiphospholipid syndrome are heterogeneous antibody and typically are directed against a protein which bind to the phospholipid. So antibody which bind negatively charged. So in the antiphospholipid antibody are heterogeneous and typically are directed against a protein which bind to the phospholipids. So antibody which bind to the negatively charged antiphospholipid on ELISA, they call it anticardiolipin antibody test, while those which interfere with the phospholipid dependent coagulation test, like the activated partial thromboplastin time or diluted, what's called diluted Rosial Viper phenotype time, this is called the lupus anticoagulant. So we have lupus anticoagulant and anticardiolipin antibody. So the lab feature to diagnose antiphospholipid antibody, we have anticardiolipin antibody or on 2 or more occasions, 6 weeks apart. So they make this criteria because this is antibody not occur just only antiphospholipid antibody syndrome, but can be occur in other conditions like sickle cell infection, which we can find anticardiolipin antibody in these patients. Lupus anticoagulant antibody, again, we need to have 2 or more occasions with the 6 week apart, in addition to one to prolong PTT or as we said in the diluted Rosial Viper phenotype time to make the lab diagnosis of the antiphospholipid antibody syndrome. So the diagnosis, at least one clinical, that we mentioned, the clinical, and in addition to one lab criteria to make diagnosis of the antiphospholipid antibody syndrome. So the treatment of these patients, those patients who develop arterial thrombosis like stroke, which is associated with the antiphospholipid, we should be treated with the warfarin as opposite to the aspirin in this patient. Antiphospholipid associated with the venous thromboembolism is one of the situation where they make these patients, they have predicted to have high recurrence rate, and this make enough evidence for long-term anticoagulant after first event. So once this patient, they develop just one attack of deep vein thrombosis or any venous thromboembolism, we should keep this patient on the long-term anticoagulant, because these patients, they are liable to have a high risk to develop another events. In women with the antiphospholipid antibody syndrome, it's likely that intervention with the heparin and possibly aspirin, which increase the chance of the successful pregnancy outcome in this pregnant lady. So we have another thrombotic condition, what we called thrombotic thrombocytopenic purpura, and as you know, this is one of the spectrum of the what we called microangiopathic hemolytic anemia, and the cause of microangiopathic hemolytic anemia can cause maybe caused by the preeclampsia, maybe caused by malignant hypertension, and thrombotic thrombocytopenic purpura. This is one of the spectrum of the microangiopathic hemolytic anemia. So here in TTP, we have an autoimmune disorder which is mediated by the antibody directed against the ADAMS13. And you know this is ADAMS13, it's a proteolytic enzyme which is disrupted the large multimer von Willebrand factor. So once we have this large multimer von Willebrand factor and this is not destructed by this defective enzyme or because of the antibody against this enzyme lead to make large von Willebrand factor accumulate inside the vessel, and this may causes cross-link with the platelet, and this lead to the microvascular occlusion. And this microvascular occlusion can be happen in different organs, including the brain and the kidney, mesentery, cardiac, and different organ. So the causes of the TTP it may be idiopathic, may be associated with a drug like ticagrelor and cyclosporine, HIV, malignancy, transplant. So we have many secondary causes of the TTP. So less commonly TTP is inherited, and here like what we call the Upshaw-Schulman syndrome, and this is actually causes by the congenital deficiency of the ADAMS13 rather than presence of the antibody directed against this ADAMS13. So clinically, these patients is mainly female rather than male, and they are young adolescent patients. These patients, they presented with the pentad, despite pentad at the time being it is less seen. So the pentad, it means these patients, they may have fever, anemia, which is the mainly microangiopathic hemolytic. It is mainly hemolytic anemia with the presence of the fragmented RBC or schistocyte in the peripheral blood smear. In addition, we have an increase of the reticulocyte. And because we have hemolysis, so these patients, they have an increase of the indirect bilirubin, they have an increased LDH, and they have negative Coombs test. In addition to the, as we said, because this large multimer bind with the platelets, so these patients, they develop thrombocytopenia, and so these patients presented with the bleeding, and the majority of these patients, they have severe thrombocytopenia with the platelet less than 20. In addition, these patients, they develop a neurological complication in the form of the convulsion, coma, paralysis, which is transient or prolonged, or sometimes the psychological manifestation. Renal, it is usually presented as in the mild increase in the renal indices, usually with the creatinine less than 2.2 or 3 milligram per deciliter, with the intermittent proteinuria, and as we said, mild renal impairment in comparison those patients with the HUS. ADAMS13 activity can be measured at the time being, and usually it is undetectable in this patient with the thrombotic thrombocytopenic purpura, and usually the level what's called less than 10%. And the presence of the antibody should be obtained before starting the treatment in this patient. And as you see, this patient, they presented with the headache, or this is the large thrombotic stroke in the distribution of the middle cerebral artery. And this patient, they have changes of the convulsion, and this is a bleeding tendency in the lower limb. And this table shows the difference between ITP versus TTP and DIC. So discrimination between these different causes is very important. So the differentiation of the DIC between TTP and DIC, those patients with the DIC, PT-PTT, it is prolonged, while in TTP it is usually normal. Again, in ITP it is normal. The fibrinogen is normal in patient with the TTP, but it is decreased in patient with the DIC, which is disseminated intravascular coagulopathy. Fibrin monomers and fibrin degradations is an increase in patient with the DIC, while it is just slightly an increase in TTP, or it is normal at all. D-dimer, which is the end product of the fibrin degradation product, it is usually increased in the DIC, but it is normal again in TTP and ITP. And because discrimination between these different type, it is very important, because in patient with the TTP, so the platelet, we shouldn't transfuse this patient with the platelet, because transfusion of the platelet increase the thrombosis in these patients. So it is we have contraindication to use platelet in these patients unless we have some severe major hemorrhage in this patient. So the main treatment here is the plasma exchange while in the IC. So the main treatment is plasma and activated protein C and antithrombin sometime. And see, this is picture peripheral blood film show. Characteristic is schistocyte, also called fragmented RBC, fragmented RBC and basophilic RBC. In addition, as we said, the presence of the indirect hyperbilirubinemia, increased LDH in these patients, increased reticulocyte. So, in addition to the thrombocytopenia, make the diagnosis of the TTP. So the diagnosis of these patients, the lab diagnosis, we have increase in the white blood cell, decrease in the platelet, the P2, PTT normal, bone marrow show normal and increased cellularity. So diagnosis in severe deficiency of the, there is severe deficiency of the plasma Adams 30, as we said, the activity is less than 10%. With or without presence of the inhibitory autoantibody, which is specific for TTP. And in the, as we said, whether it is a primary, we should seeking for the secondary cause in these patients. So the prognosis depends on other comorbidities like presence of the renal failure, presence of the underlying malignancy. So those patients who they have malignancy, usually and complicated by the TTP, this is usually this patient, they have poor prognosis. So 10% of these patients, they have recurrent, despite we treated these patients with the plasma exchange. These patients, 10%, they are liable for recurrency. Untreated patient, they have still high mortality with the 90% of these patients, they are died within 10 days of you. Don't we use exchange transfusion. So treatment, those patients, while those patients who they are treated, the mortality, we reduce the mortality 23% at 6 months. However, sudden death can be occur because of the cardiac microthrombi. So the main stem of the treatment of these patients is plasmapheresis with the replacement of the fresh frozen plasma. And actually, this replacement of the fresh frozen plasma contain Adams 13, and we should continue until we have improvement in the platelet count, improvement of reticulocyte, and we can add steroid and sometimes rituximab. We use those patients who have refractory and they have no improvement of thrombocytopenia. After 2 weeks, we can add rituximab. Pregnant lady, sometimes we may need termination, and especially if they have no response. And as we say, the platelet transfusion is not recommended and this is contraindicated in this patient. What's about thrombocytosis? Thrombocytosis, as you know, those patients, either we have reactive or we have clonal. And we mean that this patient, they have a clonal, so we have something abnormality in the bone marrow, like primary thrombocythemia, polycythemia vera, myelofibrosis, chronic myeloid leukemia, and myelodysplastic syndrome. So these patients, they have clonal disorder, which make these patients, they are liable for thrombotic risk in those patients with the thrombocytosis, despite sometimes bleeding can be happening in these patients. While the reactive cause, because underlying chronic inflammatory disorder, and because of the connective tissue disease, malignancy, acute hemolysis, sometimes iron deficiency, or replacement with the iron can causes reactive thrombocytosis, GIT bleeding, and post-splenectomy. These patients, they are complicated by the thrombocytosis. So clinically, we should seeking, most of the time, we should looking for the underlying secondary cause. And those patients with the secondary cause, the hemostasis, it is rarely affected, while those patients with the myeloproliferative disorder, they may present with the thrombosis or rarely by the bleeding. And usually in reactive patient, the platelet it is usually small rather than it is giant platelet, and these patients they have usually no splenomegaly. So this is the last slide of our lecture about the thrombotic disorder which caused by different causes, and thank you very much for your listening. We hope